Good morning, everybody. And as always, thank you so much for joining today. I hope you're having a great morning and good week, staying cool out there. We don't have any main updates this week. We'll come back. As always, we'll still continue to update regarding COVID, regarding monkeypox, regarding anything that might be important to you. Please let us know, of course, and we'll keep updates as going. We have a really fun and interesting topic today that will apply to all of our patients and all of us with Dr. Cummings presenting today. Before I turn it over, I just want to mention next week, our grand round speakers and a few stuff along those lines. Dr. Ewan Ashley will be speaking next week. And the title of his speech is The Need for Speed, Ultra Rapid Genome Sequencing for Critical Care. So we've been really excited for that upcoming as well. So we'll look forward to seeing that. And we have, as listed here, the presentation is the following week with Drs. Young and Clark. I just want to mention the one small announcement we have today is that we do have Chief of Staff elections today. Or I'll check your email and please make sure to vote. We have a couple people running right now, so please make sure to vote for that. And thanks, Dr. Warnica, for reminding me about that. That being said, again, we don't really have any updates, so I'm going to turn it over to Dr. Deborah Cotto. Deborah Cotto is the director for the Longevity Center at Stanford. And she was instrumental in helping us set up our speaker today with Dr. Cummings. Thanks so much, Dr. Cotto, for being here. She's going to field the Q&A towards the end as well, and also introduce our speaker. So, Dr. Cotto, I'm going to turn it over to you, and thanks again for helping set this grand rounds up today. We're really excited for it.
Thank you very much, Errol, for the introduction. I'm very excited today to be able to introduce Dr. Steve Cummings as our Grand Round speaker. He and I go back many, many years, and I am especially lucky that he was my mentor when I was a fellow in clinical research at UCF. If I'm in academic medicine today, it is largely because of continued mentorship over the years. He is a proud graduate of Stanford from the class of 1969. He then went across the bay to pursue medical studies and stayed on as a general internist and epidemiologist. He is a professor emeritus of UCSF, and he has served as the director of the San Francisco Coordinating Center, where he has led many, many studies, observational as well as clinical trials. Most people know him for his work, seminal work in defining the epidemiology of osteoporosis, as well as many of the medications that we prescribe to treat this condition today. He is elected to the National Academy of Medicine, and he also continues to oversee and conduct studies with regards to aging. Most recently, he has published an editorial in the New England Journal of Medicine regarding vitamin D supplementation. So our topic for today is very timely. He will be speaking on pills and vitamins to slow aging. I'm very excited to hear you speak. Thank you, Steve, for coming across the bay to talk to us.
Sure. Let me start by sharing my screen. Okay, this will stop other people's screen sharing. Yes, I don't want to see you all. Here we go. And Deborah and others, do you see the slides?
Yes, looks perfect.
Okay, that's great. Well, hi, everybody. It is a pleasure to come back to my old alma mater. I really love Stanford and come down once or twice a week for women's sports. You've got a terrific set of teams. Urge you to go out and see women's volleyball and basketball. Anyway, with that introduction, I want to thank everybody for the opportunity to talk to you about pills for aging, pills to slow aging and to promote longevity. So the issue here is that 3/4 of US adults take supplements, and hundreds of millions of pills are made every year, and this supplement industry in the United States alone is over 30 billion. So I can say safely that most of the patients you see are taking supplements. And many of them claim to slow aging and promote longevity, but they're often very expensive, and patients can spend quite a bit of out-of-pocket money for supplements. So I'm going to talk about how this came to be, first get into the history. and then get into evidence. Do pills, any of the pills, slow aging? So I'll start by talking about the history of pills, because without the technology to make billions of pills, we wouldn't have the issues we've got. And then I'll talk about the history of treatments to slow aging along the way, evidence about the efficacy of those pills. So now let's dive into the history of pills and something completely different. Actually, pills go all the way back to 4000 BC. They've been described in Egyptian papyruses as spices and plants mixed by hand with dough, honey, or grease. And they were found, first examples, in 120 BC in a shipwreck where they contained the things that you see there. But in order to keep them from crumbling, they were typically wrapped in a fabric. So there was an advance in the 16th century where ingredients were mixed together into a soft mass, and then rolled and cut by the device you see there, rolled and cut into small balls. Well, you can't handle the small balls without a coating. So these were little coating, cups that allowed you to shake the pills with a coating material to make the final ones. Those included toffee, often used for things for kids, shellac, and gold dust, which, believe it or not, was often used for patients who had rheumatic or arthritic complaints. Of course, this technology does not allow you to make large number of affordable pills. So now we got to devote a little time to graphite, and I'll tell you why we're going into graphite. It was discovered in the 1600s in a large deposit in Northumbria in England. At the time, it was thought to be lead, but it was useful for marking things, marking hides and other materials. And they were, so this is the derivation of what we call lead pencils, which are actually graphite. So later, these were used for writing and drawing. And one artist, William Brockenden, in the early 1800s, decided to make superior quality, less friable graphite, or what he called lead pencils. So in 1843, he patented a method to use dyes to compress graphite, the graphite goo or powder, to make writing instruments. You see that device on the right. But a drug manufacturer recognized its value for making pills. And so Brockenden's patent that was granted by Her Majesty was a patent for pencils and sleeping pills. So this is the origin of the pill technology, but unfortunately, it didn't lead to pencils, because about the same time, a man in Napoleon's army invented a better approach to mix graphite, clay, and then heat them into long pencils. And these Conti pencils, some of you might recognize, are still to this day considered to be the highest quality. So Brockenden's method didn't end up as pencils, but it enabled the automation of mass production, eventually, of billions of pills. Okay, so now let's go into the history of treatments to slow aging and extend life. Well, the first one that shows up is the artist's rendering of the Fountain of Youth, going in old one side and coming out young on the other side, kind of reminiscent of rejuvenation that's now become so popular in aging-related research. But the first real therapeutic attempt were to treat what were considered hormonal deficiency. Actually, for women came first, but I'll talk about them second because I find this interesting. In the 1920s, Dr. Voronhoff pioneered grafting monkey testicles. You can see them down at the lower left, into the under the abdominal skin of older men. And that led to testimonies of rejuvenation and even making immortal giants. You can see the evidence in the books below, before and after. I'm not sure that after looks a whole lot better than before, but Dr. Voronhoff set up an institute that made him quite wealthy as this became a popular approach. And treatment with female hormones started with Dr. Robert Morris back in 1895, conducting the first ovarian transplant. And it turned out that those transplanted ovaries, he reported, reduced hot flushes, and he claimed that they restored fertility. But in 1929, estrogen, the hormone, was isolated, and a number of years later, a placental extract, MNN, was used to treat dysmenorrhea. About the same time, it was discovered that pregnant mare urine had very high levels of a variety of estrogens. And indeed, estrogen was then extracted from the urine of pregnant mares. It takes gallons of urine, of course, to make enough to make a difference. It was dried into powder. And guess what? Brockington's method comes back into play, now in a more automated form. They compress the mare's urine into a pill, and that pill was Premarin, standing for pregnant mare urine. So Premarin became the number one selling drug in the United States by the early 1990s, and it was promoted to slow aging, feminine forever, and you can see the contrast between old and young in the cover of the Time magazine. So we'll talk about that first and then go on to other pills. We did one of the first studies about estrogen for mortality. That was our observational study in nearly 10,000 women. This observational study found that those taking estrogen had a 45% lower risk of death. That and many other observational studies led to us to conduct a meta-analysis of observational studies and come to the conclusion that hormone therapy should be given to prevent disease and prolong life, particularly in women with heart disease. Boy, we couldn't have been more wrong than that. I'm embarrassed retrospectively for that promotion, because, but of course, the problem we will see replicated with other pills was that estrogen users were healthier than non-users, and therefore they lived longer, not because of the estrogen, but because they were healthier. And this is all rectified by the really large and randomized trial, the Women's Health Initiative, in those with prior hysterectomy, getting conjugated estrogen or Premarin alone for 7 years had absolutely zero effect on mortality. The data is there, total deaths exactly the same between the groups. So now let's talk about vitamins. Well, the term vitamin was coined back in 1911 when a guy named Funk claimed that there were vital amines in foods that were required for health and survival. And so in 1916, the first vitamin supplement was made containing vitamins A, B, C, iron, and calcium. Well, who does not want to take a vitamin, something that is vital? And so that vitamin supplement took off. It improved appetite, increased energy, all kinds of good things for women and men. And that led now, as you know, to a whole slew of vitamins. I like to call it the vitamin alphabet: A, B, C, D, E, and F for folate. And so there is evidence, however, large randomized trials of each of these vitamins that finding no effect on mortality. The first meta-analysis published in 2019 gave us the array of effect sizes and confidence limits on the right. You see all close to 1 or no effect for mortality. That was updated, a couple of them, like beta carotene, were associated with an increased risk of cancer, albeit slow, be it low. It still is evidence that vitamins aren't necessarily free of adverse effects. Here it was updated in 2022. The US Preventive Services Task Force went through and looked at mortality, cardiovascular events, as well as any cancer, and again found zero evidence for any of the vitamins that I listed before. A, B, C, D, E, and F really have no benefit to mortality. Well, now let's turn to vitamin D, the sunshine vitamin. Who does not want more sunshine? And the benefits for vitamin D have been, numerous, certainly more so than any other vitamin that I know of, protecting against heart disease, cancer. Well, it is now the largest selling individual vitamin. 40% of people in a US survey over the age of 60 take vitamin D. And Medicare alone spent $300 million per year on testing vitamin D levels. And well, the linchpin to all of this is that when someone is diagnosed as having D deficiency on those tests, they're advised to take these supplements to treat that presumed deficiency. That's a big driver of the use of this in the general population. So, as this should be familiar, many large observational studies found that people who had low blood levels of vitamin D had a higher mortality. There are good reasons for this confounding. Vitamin D, by the way, is a prohormone, not really a vitamin. We make it in our skin, for example. So this meta-analysis of 26,000 people in observational studies found a 1.6-fold higher mortality in those with the lowest 20% of vitamin D levels. So I refer to this as vitamin deja vu, as we look back, for example, to the estrogen example, because it was followed by large randomized trials of vitamin D3 supplements for mortality. Here are three of them. The most famous now is VITAL, a large trial that has many components, where 26,000 people were randomized to what was considered, and still is, an ideal dose. Absolutely no effect on mortality. And in addition, the randomized trials of vitamin D3 have large and well done randomized trials have been done for all of the clinical indications you see here. No effect on cardiovascular disease, cancer, kidney disease, even survival in the ICU, no effect on falls, and of course, most recently, the no effect on fractures, which has been accompanied by trials that showed no effect of vitamin D on BMD or bone quality. Okay, but I think it's 11 of those large trials had vitamin D levels, had vitamin D stored, blood for vitamin D measurements stored at baseline. And in every case, they've shown that people with deficient vitamin D levels, typically less than 20, also have no effect. So those with deficiency have no benefit when the overall trial shows that it's negative. That's also true for people who are labeled deficient. Here's the example from the recent fracture trial where baseline vitamin D levels were measured in this large trial that found no effect on the risk of fractures. There was no effect in those whose levels were less than 20, and even the small, modest number, about 15 people whose level was less than 12.5 or severe deficiency. And so in the VITAL trial, there's been no effect with vitamin D on cardiovascular disease, cancer, mortality, and such. So as Deb referred to, we published what is, I'm sure, going to be a very controversial editorial, that for the general population, vitamin D does not reduce mortality, or promote longevity, or prevent any of the major diseases, even in those classified as deficient. And so I think it's time to stop testing vitamin D levels to come up with deficiency, which drives so many people in the population to take vitamin D supplements unnecessarily. Okay, however, there's another side of this. Vitamin D severe deficiency can have a number of adverse effects or symptoms like those of osteomalacia, and people who are deprived of sun or vitamin D in the diet should probably be supplemented, although there isn't trial evidence for that. Malabsorption due to GI disease, surgery. Some drugs like zoledronate that are given can cause hypocalcemia, and it probably is worthwhile giving vitamin D in advance to prevent hypocalcemia. And clinical syndromes probably warrant vitamin D levels for it as a diagnostic test, but not as a supplement for the general population. Now, vitamin D is in second place because in first place are multivitamins. In this survey, again, 60% of the population in the United States, they estimated, were taking multivitamins. Cover your bases. Get all of the vitamins in one pill. And this is the award winner that I've been able to find online. Ultimate Multivitamin has 33 ingredients, including 14 vitamins, 13 minerals, 16 botanicals. And guess what? It's primarily promoted for supporting longevity. Probably the most common claim that you'll see on the web for supplements and vitamins. Well, the U.S. Preventive Service Task Force did a specific meta-analysis for multivitamins in various combinations, and again showed that The multivitamin supplements just as well showed no effect on all-cause mortality. Well, most recently, pills have been promoted on the basis of science. But by that I mean, usually studies in vitro and in mouse models, sometimes in worms, that come up with support for some theories of aging, and that these pills will address those causes, fundamental causes of aging. So let's dive a little bit into these theories of aging and the supplements that arise. Now, for a long time, oxidation and antioxidants to prevent oxidation has been around. We'll talk about that. Nicotinamide adenine dinucleotide, or NAD supplements, also very common. And most recently, there is a growing supplement business around cell senescence. Okay, where's the evidence? Well, first of all, you've got to remember that supplements that are based on science, generally derived from mouse models now, these cellular pathways have been discovered and then tested in experiments for lifespan in mice. Now, that's important to, of course, remember that mice and humans share 98% of their genes, but mice, particularly laboratory mice, live 3 to 4 years. Humans live 80 to 85 life expectancy. Mice die of cancers. They don't die as humans do from heart disease, stroke, and degenerative diseases. Now, so oxidation, some of you may be familiar with, it's believed arises from the metabolism of carbohydrates and lipids oxidized to produce ATP, energy. This goes on in the mitochondria. But as a byproduct of generation of ATP by oxidation of those substrates, you also generate reactive oxygen species, or ROS. This is a very highly reactive form of oxygen. You can see the molecular species below. And I put little red dots there to represent ROS, the oxidizing species of oxygen. So, since ROS reacts with many components of cells and the mitochondria, it can cause oxidative damage, which may lead logically to cellular dysfunction and cell death. I've illustrated that below. It's believed that, again, oxidative damage reacting with many of the components of cells can lead to cell death. It can also sometimes trigger cell senescence. We'll get back to that. And so this is a pretty well-established theory of aging until probably the last decade, where some evidence has arisen that maybe the reactive oxygen species are good for you. I call this the rust away theory, that we may rust inside and out as we age, leading to premature death. Well, antioxidants are extremely popular supplements. You can go online and find superoxidant antioxidants, multiple antioxidants, things like Eternus that suggest that if you take the antioxidants, you may live on for an eternity. And of course, now everyone promotes antioxidant foods, blueberries and such. It's, we will continue to have antioxidant foods. I love antioxidant foods. I love blueberries. I'll take them on the basis that they taste really good. I'm not sure that I'll be eating them for the purpose of antioxidant properties. So there've been a randomized trial of antioxidant vitamins, and this one 13,000 randomly assigned to antioxidants that included vitamin C, A, E, beta carotene, along with selenium and zinc, and there was absolutely no difference in the overall mortality over the course of that long period of administration. And you can go back into the mouse literature and find that there are experiments showing that antioxidant vitamins, here vitamin E and vitamin C, you can see shortening lifespan by comparison to controls. So there are instances where they might even have adverse effects. Certainly on mice, you begin to wonder whether that might be true for humans. So let me see. Now let's go on to NAD supplements. Now, NAD is still very popular in the aging industry and among colleagues who are doing aging research because it's a coenzyme that's essential to many metabolic or redox reaction in cells. We know that the levels of NAD decrease with aging pretty steadily. And experiments in mice like this one in Science 2016 show that NAD repletion in mice improved mitochondrial stem cell function. And as you can see in the graph on the right, the NR, or a form of nicotinamide, which causes increases in NAD levels, in fact, resulted in longer lifespan for mice. Now, the supplement industry noticed that literature and really caught on quickly and has been promoting NAD. NAD plus, life extension, cell regeneration, boost your NAD levels. These tend to be relatively expensive supplements, again, promoted on the basis of the mouse studies that I showed you. Now, here's an example where I have friends in the aging industry who are taking Basis. Basis is a supplement that's designed to raise your NAD levels, and it's promoted to combat cellular aging, improve cellular energy pretty quickly. And there are testimonials that are on the Basis website of people having immediate improvements in sleep, feeling more energetic, stronger, quicker. Well, you can get this if you'd like to. You can go online and spend $40 per month as a subscription, $480 a year for Basis. This comes out of a company called Elysium. We'll return to them. And it was founded by Leonard Guarenti, probably one of the most prominent people in the aging research world. And indeed, Basis, formulated again by Elysium, has been endorsed by Nobel laureates. You see them on the right. And also a number of prominent people in aging research have been shown on the Basis website. And, really, that's the evidence for the supplement in humans, except for one trial that Elysium sponsored. And here, this is essentially Basis, was shown to dramatically increase NAD levels in humans. This was a randomized, double-blind, controlled study that in 120 people, not a huge number, but it was enough to be able to detect the effects on continuous variables that we might use to assess its effect on aging syndromes. Well, indeed, as you see on the left, that supplement increased NAD concentrations 40, even 90% in the higher dose. That's dramatic. If anything's going to have an immediate effect, it's going to be Basis. However, that increase in NAD levels, even to 90%, resulted in no improvements in fasting glucose. Well, that should have happened pretty quickly. Blood pressure, no. 6-minute walking distance, no. 30-second time chair stand, no. Self-reported sleep, no. Well, it had one effect. It increased LDL cholesterol significantly, which is exactly the opposite of the effect you see in mice. Now that's, so what disturbed me most about this finding is that it was buried. It has never appeared on the Basis website. That there is a really small footnote that you have to follow in order to find this result towards the end of that randomized trial report. No additional studies of Basis are planned. Now let's turn to senescence and senolytics, an area about which I am probably positive about, and there's a lot of excitement about cell senescence. So I'll give you a cartoonish introduction to cell senescence and to senolytics. Now, cellular senescence is a situation where replicating cells stop dividing, but they, for reasons of certain intracellular processes involving enzymes such as P16, lead these cells to survive but accumulate in tissues. Some people, and I like to refer to these as zombie cells. as you can see on the lower right, I have colored the zombie cells green. Those are senescent cells that have persisted in tissue, not replicating, but replicating cells begin to produce inflammatory cytokines and other molecules that now generally referred to as SASP. SASP is released by these cells, and they permeate tissues and can be in the circulation. They can cause cell dysfunction and cell death. And we've done research recently showing that higher levels of SASP in the blood are associated with adverse effects, such as the occurrence of mobility disability and slowing of gait and other aging-related consequences. But again, this is beginning to sound like a familiar story, although the science, I think, is interesting. Well, senolytics are an interesting type of drug because short courses, a few weeks even, can kill senescent cells. And it's sort of like an antibiotic killing bacteria. Senolytics, in fact, can kill senescent cells, clear a tissue of senescent cells, and decreasing the levels of SASP perhaps will have benefits for the aging-related syndromes. So are they beneficial? Decreasing cell senescence is useful for wound healing. And getting rid of senescence evolved to probably decrease the incidence or the growth of cancer cells. So, the jury is out about whether there are any harmful effects. And there are dozens of randomized trials. The very first one, reported a year or two ago, that had a strong biological basis, was for osteoarthritis by a company called Unity, whose stock you can buy. And it had no effect, absolutely no effect on OA. They just reported that the administration of an NAD promoting supplement into the eye leads to an improvement in macular degeneration, still not published. However, it's going to take a long time to determine whether or not senolytics extend healthy survival without any adverse effects. Well, that hasn't stopped the industry, the supplement industry, from going in whole hog to promoting senolytics. There's a label from anti-aging senolytic treatment. The Life Extension company has gotten into senolytic activators. You'll see Ficitin. I like Ficitin. I actually tried it for a while to see if it had, the immediate benefits that would be expected from acute treatment of for me, at least, it didn't work. Don't count that as evidence per se. But the interesting thing is Ficitin is an extract of strawberries. And that's where you get Ficitin from. It's a strawberry extract. You can buy it in the store, but it requires probably a couple of pounds of strawberries in order to have the kind of level of Ficitin that's been used in trials as a senolytic agent. But Elysium has now gotten in the game, and they now promote senolytic capsules, which are almost as expensive as their basis supplement for promotion of reduction in cell senescence. So, so it's really interesting how now the science has been invoked now to support this massive pill industry. And so let me summarize, a little bit more to say, but the invention of pencils enabled the mass production of pills. Millions of people now, it's enabled millions of people to take pills that claim to slow, reverse aging, reduce mortality, and extend life. But large randomized trials that have followed on the observational evidence have shown that these pills do not reduce mortality, and it's possible a few of these and maybe things that are tested in the future might prove to have adverse effects, which is a good reason to be cautious about their promotion to patients. Again, I'd say a majority of your patients are taking them, and you might ask about them and discourage them from using their good money to spend on other things besides the supplements. There is no pill, you can tell them, that slows aging or extends lifespan. Now, does anything work? This is kind of a bummer talk. When I give it about this point, people, get depressed or leave the lecture hall. So let me see. Yes, there is some, it's not perfectly clean, but there is, I think, very good evidence and some trial evidence to support. Excuse me, let's go back. This, cancel this thing that popped up. Moderate exercise, most days, or vigorous exercise 3 days a week, has some evidence behind it, trial evidence, that it may reduce mortality. Some of those are below. One of my favorite trials done in very old people of an Otago method that was exercise 3 times a week and home-based exercise to build strength in about 4 randomized trials for prevention of falls, actually also showed a benefit, about a 50% reduction in all-cause mortality in those very good randomized trials. So I'm bullish on exercise. And it leads me to my conclusion, which is in order to extend healthy life, you should advise your patients to walk, jog, bike to a supplement store if they must go there, but don't buy the pills that they sell. So let me stop there and say thank you for the opportunity to talk to you all, and I hope that this was an interesting presentation. Thank you. Oops. See if I, let's see, I'm going to try to get out of this and show and stop sharing. Okay, there we are. Let me turn up my sound so I can hear you. I do not hear you.
Well, thank you. Do you hear me now?
I hear you now.
All right. Well, thank you so much for such an interesting and well-presented presentation for us today. It's certainly thought-provoking. And I think I'll just start by, just as you ended with kind of pills to slow aging and where the evidence is, et cetera, all of those other vitamins that have been studied more rigorously and thousands of people in randomized controlled trials, it's actually quite impressive that every single one of them has not shown to have substantial health benefits so I'm wondering, as you've delved into this topic, are you surprised by this? Are you not surprised by this? And if you regardless of your answer, what are your thoughts about the fact that the trials are not supporting supplement use?
I took vitamin C to treat my colds. I was really excited about vitamin C decades ago. And I really liked the idea of vitamin E. I thought that was going to be beneficial to appearance and skin. So I was a supplement user. And then these trials began to appear. And it began to develop into a pattern, and that pattern really starts with the concept of Vita. And as I think back about this whole industry, who does not want to take a Vita? And people, particularly those who, don't feel as good as they'd like to, they want to take a Vita. And so this industry, I think, is supported by that language, and has been, for many, many decades. And, it's hard for people to believe in randomized trials. When I've given this lecture and I've talked to lay audiences, the hardest concept to get across is randomized. And the observational evidence still is promoted in your news feeds and sometimes in medical journals, showing that people who take these vitamins do better than those who don't. And where it can be measured, levels, for example, of vitamin D, those people who have low levels have an increased incidence of bad things. So altogether, the use of the term Vita, the promotion of observational study evidence, in the sense, maybe these can't be good for you, or as Joanne Manson said about vitamin D recently, well, I'm going to hedge my bets. I realize there's no good evidence here, but, sort of like praying every month or so, you kind of edge your bets getting into heaven. You know, you don't, it is really something that's difficult to get across, I'd say, even to physicians, particularly when you can measure it. When you measure something and it's low, you got to fix it. Deb.
Yeah, well, thank you for your thoughts on that. I'm just thinking, this has been an interest of mine for quite a few years. I worked in B vitamins back in the early 2000s in homocysteine, for example. And the only evidence that I really still believe in is I want to pull out folate from your list.
Oh, yes.
Women who are expecting, I think that evidence is clear. So I don't want to throw the towel on folate in the appropriate populations. That being said, there was a comment about estrogen and the fact that the WHI was published many, many years ago now. And it really changed the practice of medicine substantially. It had a huge impact. And being fortunate to have been, having been in this field in women's health for many, many years, there are, in terms of, there was a question about mortality. I think more recently they've looked at long-term follow-up from WHI, have not shown any mortality benefit from taking the medication. That being said, for symptoms and for the younger populations, I think that's pretty clear. And I just would like you to perhaps comment on the subtleties of estrogen replacement or hormone therapy in.
Sure. This is about longevity, and it's longevity and slowing aging and reducing mortality, because that's such a driver of this industry. And it's an industry that's for the general population. And that's, you know, I think that if you've got 3/4 of your patients taking supplements, that the vast majority of them are taking for that purpose, not for a treatment, because it's true. A couple of things on that list treat diseases, treat conditions, or in the case of estrogen, for example, they treat menopausal symptoms very effectively. And there is some evidence, you know, that they may have other health benefits. It's controversial, but maybe preventing cardiovascular disease with estrogen alone. Getting into very, very specific indications in some populations. And folate for women who are pregnant, absolutely. And vitamin D, where it's become, I think maybe we fueled some of the controversy, and you might go there, Tim, but there are indications, as I indicated, for patients who've got conditions, patients who have diagnoses, patients in certain specific circumstance, for which it's worth giving, even probably in the absence of trial evidence that'll never be there.
Thank you. Another question is that lately we have seen a lot of observational studies that are using propensity matching to try to reduce that type of confounding, and that we see in the estrogen and vitamin D studies. Do you think that analyses of these studies using these matching techniques would change the results?
Well, they might change the results. Propensities analyses are cool. I like them. And I think that there are instances where they seem to have changed the results of studies, maybe making them more sensible. But boy, if I have a choice between a propensity matched observational study and a large, well-done randomized trial, I'm going to choose the randomized trial every time. And there's also, you know, there are a number of other methods to try to rescue observational studies. And I think that that's really interesting, but, you know, it does not fundamentally change, you know, the quality of evidence that you should rely on out of randomized trials.
Yes, and your point from earlier is well taken. As another question, really, there have been so many observational studies, and this person is asking about the low vitamin D levels that have been shown repeatedly to be associated with higher breast cancer risk in communities of color, and really large studies, like over 50,000 people, and how you would comment upon this. And they were specifically saying Black and Hispanic women.
Okay, so there subgroup studies in those subgroups in those large vitamin D trials for cancer. Now, I don't know. I don't know the 50,000 woman study of vitamin D for prevention of cancer. If there is one, it'd be massive and should have appeared on the radar screen. I haven't seen it, but I know of the randomized trials for cancer, very large studies, and they have been negative for cancer. Now, there are a lot of subgroups that are done in these large randomized trials, and subgroups isn't yet another thing that we could talk about in another grand rounds. But if you do enough subgroup analyses, you're likely to find something that's significant by chance alone. So there are occasional instances of that where no effect overall. But if you wait 3 or 4 years after the randomization and you look at their mortality back only in Blacks, you see a small, statistically significant difference. So that gets back to the question. If you're doing, I think by now, hundreds of subgroup analyses, how certain are you that what's being promoted is not a chance effect? It's interesting. It's an interesting longer discussion. But those have not been tested in the right way for interactions typically. Okay, so the bottom line here is that yes, it's possible to find certainly observational study evidence that suggests, and occasional subgroup analyses of large trials that suggest that there might be benefits or subgroups. I'd just be mindful of the main effects. The main effects of the trials are very clear. And so observational data, again, I'll leave it at that, right? Because I think it's a very good question around which we could have another day's debate.
So, thank you. So one person has asked about could you comment about the effect of testosterone and growth hormone on aging in particular?
Oh, you caught me with, these are not areas of my expertise, so I'm likely to say stupid things. So I'll have to minimize what I do. I am involved with the aging trial industry, so I know at least about the growth hormone trials that have been done largely to treat sarcopenia and have functional benefits. And indeed, testosterone can increase muscle mass. And it does have some effects on mood and sex or libido, not just in men, but it's also, I think there's evidence that that's true in women. So testosterone may have those kind of benefits. I know of no data that testosterone has any benefit, excuse me, for mortality or longevity. Growth hormone is really interesting. Again, it's been tried for sarcopenia, and a compound by Merck was used for improving the functional benefits of sarcopenia or mobility more largely. And they abandoned that because their trials, although it raised growth hormone concentrations were the things that they were after, had absolutely no clinical benefits. So I'm not familiar with growth hormone as having certainly any benefits for longevity or aging. Let me flip it around. You look at mouse models, and the mice models that really live the longest times are those that are growth hormone knockouts, IGF knockouts. And so getting rid of growth hormones, making the mice small, really seems to dramatically improve their lifespan. And so I'm a little bit nervous about growth hormone studies and all the growth hormone that's given in some cultures to increase stature, because at least the mouse evidence suggests that growth hormone is bad for longevity.
Thank you. So keeping an eye on the time, I have a few thoughts, but someone is asking you about rapamycin and anything to improve memory. Those are kind of specific aging related questions and supplements.
Oh, sure. No, there is a lot of popularity among rapamycin, also metformin. Those will probably be, as soon as they put the funding together, they've been trying for 4 years to put the funding together for a large metformin trial. I suspect there will be randomized trials. Rapamycin tends to have toxicity, so that I don't know of any large trial of rapamycin yet. There are rapalogs, analogs of rapamycin that might eventually be tested for that. But we don't have trial evidence in humans for rapamycin, rapalogs, or for metformin. Looks promising biologically. They seem to have interesting biological effects. But remember, that was also true for antioxidants, probably most strongly. And senescence is on that list. So far, the trial evidence is just not there. And certainly NAD is a great example of something that was extremely popular for its anti-aging. I just hope that this is just not another story of the same sort we've seen. Let's see about metformin, see about rapamycin, invite me back in 10 years.
Yeah, well, my personal opinion is that we won't see a huge benefit, but I'm not sure. There was a comment specifically about asking about Prevagen, which a lot of patients in geriatrics come in because they are concerned about memory, and that's an example of a very well-marketed memory supplement.
So teach me about that, Deb. What is it?
Oh, it's available, and it's like if you're worried about losing your memory. Prevagen, Prevagen. So I will answer, there are no good data to support spending money on that particular pill, but it's an example of an outstanding marketing. I'd like to just interject a comment that really to date, where we are in 2022 is that, and even prior, is that randomized controlled trial data are the best data that we have on hand. And starting out with Steve as a fellow, making use of large epidemiologic data, observational studies are great for hypothesis testing. We can find all kinds of interesting associations that lead us to those randomized controlled trials. But in fact, that is the gold standard. And Steve, I loved your article with Cliff, but you guys did not point out the one positive effect that I saw come out in BMJ on autoimmune disease with vitamin D supplementation. I think they did find that. So if you dig deep enough, you can possibly find these signals, but for the overall population, for the people they studied, and without the randomized controlled trial evidence, it's really, you'd be hard pressed to take these and believe that they actually work. The other point that I like to make to patients is the supplement industry is huge, but these are not FDA regulated supplements, and they can make claims short of cures that look really, really attractive, but they can be very misleading. And there are adverse effects that happen when people take these medications that they don't think of as medications. They think of them as supplements. So those are things that I just like to impress upon the audience.
Deb, if you don't mind, I'll add one more thing to harms, because really our medical harms are not very prominent in the industry. These are largely probably safe, but where I've seen the adverse effect that's maybe harder to describe is people trusting them. Remember, in the osteoporosis field, people believing that vitamin D and calcium is all they need. They're recommended, you hear so much about it and you begin to trust it. And you begin to trust that taking your supplement may be all you need. Maybe you don't need to exercise. Maybe taking supplements will reduce, as some people say, reduce your cholesterol. Maybe there are benefits that allow you to ignore or not follow through on things that are really proven to be of benefit to you. So I think the biggest, maybe the side effect that I worry most about comes from belief in them. So yeah, jog and bike to the store. Don't believe in them and don't buy them.
Someone writes, awesome presentation. Do you have data BMI and clinical and outcomes? Is weight loss the ultimate vita?
Weight loss? So I believe in weight loss, and I need it. Personally, I need some. I think that there's good observational data. I don't know yet. Someone can enlighten me about whether there is a trial evidence, for example, from bariatric surgery. And I think the most dramatic demonstration of a benefit to weight loss might come from the dramatic effects of bariatric surgery, as well as some of the very dramatic weight loss drugs that are, I guess, are now used for diabetes. I'm not an endocrinologist for diabetes, but I think that some of the things that have dramatic effects on are the ones that most likely to be trials that show a mortality benefit, and I would be surprised if they didn't. BMI is a strong risk factor for almost every adverse consequence we study in aging, and it's a stronger association with good evidence to back up why that would be true. So weight loss, yay! I'm waiting for trials maybe I've not seen yet that prove the point.
Okay. Someone else writes, although calcium supplementation is recommended for osteoporosis and not for longevity, could you please comment on the safety and efficacy of calcium supplementation for osteoporosis? And is there a good evidence to support the claim that the calcium supplement use is associated with an increased risk for coronary artery calcification?
Okay, that's great. You've touched on all that. This is somebody who's really familiar with the calcium controversial area, and I should probably turn over the microphone to them. Not an area of my specialization, though I track it and track all the trials and meta-analyses since I'm in that field. And the vast majority of the meta-analyses that have been done, some have said there are more meta-analyses of the calcium than there are trials for calcium. If they show benefits, it's been extremely small benefits, maybe for reduction in hip fracture risk, maybe, but there are meta-analyses to the contrary. And you're referring to a group in Australia in particular, New Zealand in particular, who have some evidence that it increases the risk of cardiovascular disease. There's not much more to be said about that, except that the effect of calcium on osteoporosis is so small that this is another instance where people obsess about the dose of calcium, when they should take it, how many times a day, should they take it with food or with not. Forget about that. Let's talk about effective things for your calcium, because if it has an effect, it's very small.
Yes, and as I see patients here for osteoporosis, and I'm a geriatrician, I'd say that the incidence of constipation is greater than the effect that I can measure on bone. So we have just 2 minutes left, and maybe we'll turn it to a clinical question. Wonderfully talked, beautifully illustrated. Most of my cancer patients ask about vitamins. Can you share ideas on how to educate them?
Well, I have to say, it's really hard because in the talks to the general audiences, the key concept that's so hard to get across is randomization. It's not easy. And I try to use many examples of it because in their everyday life, not the few minutes that you spend with them, they'll be bombarded with various kinds of claims, and studies show that don't come from really good randomized trials. So you have to say, the evidence, what we know that's really gold standard, says that this doesn't work. And maybe they will trust you as a mediator of the evidence. And you know that the randomized trial evidence is strong, and you can say, boy, the good evidence, the really rigorous evidence says doesn't work, and you're wasting your money.
Thank you. And in the last minute, someone wrote about a very key question that geriatricians think about a lot. He says, wonderful presentation. Thank you. Curious to hear your thoughts on how vitamin supplementation has affected other outcomes that measure more the quality of life rather than the length. So is really mortality the correct outcome? And should we be thinking about other things that matter to patients as they live?
I know of no evidence that any of the other vitamins have any effect on anything that's meaningful in the way of quality of life. There are going to be controversies around the vitamin D literature because, I think I reviewed 150 of these trials, and there are a number of small trials. Somebody in their office randomizing, they say, their patients with COPD or patients who are receiving, for example, treatments for drug addiction, where the vitamin D is given to a relatively small group and they seem to improve their sleep. There are a lot of those. You have to be really careful about publication bias, because there are a lot of really small positive trials for benefits on quality of life. And the other part of this, that likely negative or trials go the other way, that you don't see them. And I suspect that they don't get published. So yes, quality of life, maybe. Are there really good trials? Really good? I'd say all of the very large, extremely well done, all of those are negative. And some of the smaller ones for other kinds of benefits they promote, some of those are positive. So the jury's out. I wish the evidence were better.
Thank you again so much for such a wonderful talk. And it's 9:01, so I think we should end about now.
Thank you, and thanks for the opportunity. I'm going to be down there on on Friday for the first women's volleyball game. Hooray! Support the teams. Bye. Go Cardinal.
Thanks, Steve.
Bye-bye.
Dr. Cotto, thanks for organizing, and Dr. Cummings, thanks so much. Everybody have a great day.